Buenas tardes a todos. Vamos a dar inicio a esta nueva sesión de nuestros seminarios académicos de Facultad de Medicina y SIM. Y vamos a recibir a Paula, que es la anfitriona principal de nuestro invitado ya regular, Craig. Craig, welcome back. This is the last time you give this talk in English. And next one will be in Spanish. All right? Paula, el escenario es todo tuyo. Bienvenidos.
So, well, we'll be very quick. So it's an honor for us, for me, and for the group, for the clinical research group, to have Professor Anderson here. He's a neurology and epidemiology professor at the University of New South Wales, and he's also part of the clinical research center at the UDD. Actually, he's a visiting professor at UDD. So he comes every year to work with us. We collaborate in a lot of projects, clinical projects, within the network we have with Clínica Alemana, with Hospital Facultad, and also with other hospitals in the country and also in Latin America. So he has a lot of experience coming to the country for research, but also to enjoy a little bit and have fun. So again, it's a pleasure for us to have him talking about blood pressure and stroke. This is his main topic in his career. So thank you very much.
Thanks, Paula. And good afternoon, everybody. It's my pleasure to be back here at UDD in Santiago, Chile again. And always look forward to coming back here. I've been doing it now for almost 20 years, so quite familiar. And but getting the visa into Chile is more complicated now. But anyway, so look, the title of my talk was around blood pressure control and stroke prevention. I've modified it a little bit because I want to talk about intracerebral hemorrhage from a blood pressure point of view, because of all the types of stroke due to bleeding in the brain is just so dependent on blood pressure. So if we talk about blood pressure control, this is the classic model for how it can be beneficial and applied more generally. And the other thing I'm doing, I'm just taking the liberty of testing out my presentation for you. So it's a two-way task today, because the American Heart Association are having some webinars at the end of the month, and I've put this presentation together. So that's why it's got the logo here, so that I can see how the presentation goes for you. You can give me some feedback and everything on this as well. So in any presentation now, you know, we have to, how do I? Is it working?
Yeah.
This one.
I don't have to use the...
No, there you go, now.
Okay, so my conflicts of interest, so I have an editorial role on a journal, and I receive grants from government and from industry, which is pretty essential now if you're a researcher getting research grants. So look, why would intracerebral hemorrhage be important? Because actually it's what we would call the Cinderella of stroke, and it's been that way for a long time. And part of the reason is that it's less frequent than the more common blockage of blood vessels in the brain, ischemia. And the other thing is that we haven't had a treatment. So as a doctor, trying to treat somebody with a bleed in the brain is very challenging for us. And we feel that, well, we can't do very much. We don't have a sort of an urgency. But actually, intracerebral hemorrhage is a huge problem. And it's a big problem here in Chile. Probably 1/5 of all your strokes here are a bleed in the brain. And you can see here by this global pattern, the global burden of disease study, they've mapped out where the rates are very high. And you can see here that in Asia, there's a very high risk of bleeding in the brain, and it's very strongly related to high blood pressure. But what I want to show you is that bleeding in the brain is a classic example of deprivation. If the population is poor and deprived, this is a very strong disease burden for them. And then as you become more wealthy and you have more urban lifestyles and change your diet, you get fatter and your blood vessels harden and you get blockages and you get more coronary disease and atheroma in the blood vessels here, and you get ischemic events. But if you're poor, you're skinny, and you have high blood pressure and you get a bleed in the brain. And so in this global burden of disease study, I just wanted to point something out. So this is the incidence of, or the absolute numbers for ischemic stroke and hemorrhage. So they've worked out the estimated numbers. So ischemic stroke, 7.6 million cases, and intracerebral hemorrhage, 3.4. So if you just count the numbers, more blockages than bleeds. But then you go over here to this metric. This is what they use called disability adjusted life years, which is living free of disability. And you can see here that actually it's 68.57. It's higher than for ischemic stroke. So this is the dilemma for bleeding in the brain. It's less frequent, I just said 20% in Chile, but it's more severe in terms of removing people from the community who are productive. It affects people at a slightly younger age, higher death rate, more disability. So as a burden to the world, bleeding in the brain is a big problem. And I just want to let you know about a study that I've recently collaborated with colleagues in Mongolia, and I know there's been some very nice population-based studies of stroke here in Chile, and I was fortunate enough to work with these people in Ulaanbaatar, Mongolia. I can tell you Mongolia is the hemorrhage capital of the world, and this publication, it's under embargo, but it'll come out in Lancet soon. I shouldn't be saying that, but it'll be coming out. And we mapped out, we just counted all of the cases of stroke in Ulaanbaatar, the capital of Mongolia, over 2 years. And I just want to point out here that the risk ratio for bleeding in the brain in Mongolia is 8 times higher than anywhere else. And here's the Nubel study here in Chile, which Pablo Levardis and others did. You can see here that even in your population compared here, very high rate. And I just also wanted to point out again the characteristics of people who get hemorrhage or strokes. Average age, you can see here, is around 60. In North America and Australia, the average age of a stroke in my population, 75. So again, low resource, poorer population, younger people, working age, and more men. And this is income in the Mongolian Turk. It's about 50 US dollars to 100,000. And so you can sort of see the annual income here is, if you do the conversion, it's annual income is about 2,000 US dollars a year for the family. And half of the population have schooling above high school. And so what's the consequences is here. So this is what we call 28-day case fatality, so death at a month. And this is modified Rankin scale, which is a standard metric that we use to measure disability. It's a scale from no symptoms to increasing dependency. 5 is bedridden, 6 is mortality. So for all stroke, about a third will die within a month. For ischemic stroke, it's 15%, and for intracerebral hemorrhage, it's over 50%. Half are dead within a month. And for disability, this metric here, disability for intracerebral hemorrhage. Can you believe 83% have either died or are severely disabled? So that's the thing with bleeding in the brain. It's a, sorry, quick interruption. There's a laser pointer here. Oh, okay. Just a little bit here. So I also wanted to give you a little bit of an update on this big trial that we've just completed again, just to re-emphasise the characteristics of people who have bleeding in the brain. And this is a big trial that we involved Chile and other countries in, called Interact 3. And we did something unusual. So instead of the conventional randomised controlled trial, where we randomised individual patients or subjects, for this trial we randomised hospitals. So within a hospital there'll be clusters of patients. And for this trial we didn't examine a single treatment, we examined systems of care, a package, a bundle. And the bundle was rapid and intensive management of blood pressure when they come in, because often people with intracerebral hemorrhage present with their blood pressure elevated. We got glucose under control with targets. We got the temperature controlled quickly, and we reversed if there was any problems with their clotting mechanism in the blood. And we use this particular design called stepped wedge cluster randomised trial. And the idea is that there are phases, and all of the hospitals start off as a control, usual care, and they step, randomise over to the implementation of the intervention, the care bundle. It's like a quality improvement program. We've done this for several years, big collaboration, over 120 hospitals, over 7,000 patients included with bleeding in the brain to see whether this would work. And the results will be published in another month. It's been very successful for us. And I wanted to show this in terms of the characteristics of patients in different parts of the world. So this is your part of the world here, predominantly Latin America, also include Nigeria just for convenience. You've got China, where most of the patients come from, and then Asia. And again, this is 60s, most male. They're skilled occupation. This is sort of professional occupation. 20%, maybe a little higher here, 30%. So most of the people are unskilled, low education, poor, and most have hypertension, and it goes up in Latin America. And but then the profile of cardiovascular disease changes. So here's a classic one, like diabetes. So as you become a richer community, fatter, more diabetes. So it's interesting how diabetes here, 9% in China, 22% in Asia, and about 20%, 17.8% here. Atrial fibrillation, the fluttering of the heart as you get bigger. Your heart gets a bit bigger, more pressure, you can get a little bit more fibrillation. 1% here, 6% here in Latin America, and coronary disease goes up. So the profile, the pattern of patients changes as their lifestyle and their living environment changes. We also looked at where the bleeding in the brain was. So the location of the hemorrhage, deep in the brain, it goes down as the change of the population. And so maybe a fifth, it's on the surface of the brain. And we know that now that as the population gets older and there's more aspirin and anticoagulation being used, there's more superficial bleeding rather than the deeper hypertension bleeding. and the volume didn't seem to change very much. So I put that as a preliminary because, you know, that's the pattern, the type of patients, and what about the role of blood pressure? So this is very nice data from, it's called the Kadoorie Biobank study. It's been going now for about 14 years. It's 500,000 Chinese participants who have been free of disease, who've been followed up longitudinally. It's a cohort study. And you can see here that the relationship between blood pressure and stroke is almost linear. This is for coronary disease, ischemic stroke, but steeper for intracerebral hemorrhage. And if you convert this pattern to what a treatment effect would occur, so if you take a blood pressure pill or two, generally you can get about a 10 millimetre reduction in your systolic blood pressure. And if you can achieve that with one or two pills, you'll get a big effect in terms of preventing intracerebral hemorrhage compared to the other types of stroke. So again, strongly related to blood pressure and a bigger effect of treatment. But when we talk about blood pressure, there's more to it, and there's a very strong dietary component. And a big factor for diet and blood pressure is salt, sodium. And in some populations, this is again Mongolia, they have this very salty tea. It's a cultural thing. Pour an enormous amount of salt into their tea. And but then soy sauce, spicy food. With spicy food, cooking in Asia is a lot of salt. And so salt, and then the other issue is potassium. And a good source of potassium is fresh fruit and vegetables. So this is again data from the Kadoorie Biobank study, just measuring, again, reported consumption, frequency of consumption of fresh fruit and vegetable. And as your consumption goes up, you get a linear drop. And here's hemorrhagic stroke, a much steeper drop with more fresh fruit and consumption. So these are observational data, and they has always created a lot of controversy because observational data is just association. It doesn't always mean cause and effect, and that's why we have to do randomized controlled trials, because randomized controlled trials change something to prove an outcome. And that's why it's on a higher level of evidence base in experimental design. And I want to refer to this because I think it's a landmark trial called SAS, which was led by my colleague at the George, Bruce Neal, and he wanted to test whether if we put people on a low sodium diet, it would prevent cardiovascular disease. So they randomised these villages in rural China, included over 20,000 adults with hypertension or cardiovascular risk. And the advantage of going to rural China is that you can modify the diet much easier than in a city, because most people cook and eat at home rather than going out. Much harder to do it in an urban environment. And they put, according to this cluster randomisation, they put people on a reduced sodium, potassium enriched salt versus usual care. And they followed them up for several years, two or three grants, all government, no industry support. And it was well powered for just a small reduction in blood pressure. Before I said with a pill, you can get blood pressure by about a 10 millimetre. With diet, it's much smaller. But even 3 millimetres could bring about 30% reduction in stroke. And lo and behold, on all of the endpoint, positive result. Massive reduction in stroke, cardiovascular disease, and even here, all-cause mortality. You'll never see that in a randomised controlled trial in cardiovascular disease, all-cause mortality, without any renal or metabolic effects, because clinicians, biochemists might worry, oh, if you're giving a little bit more potassium, it might affect their body and cause more metabolic disturbances, but it's very safe. So it's a proof of concept that you do derive health benefits by reducing your sodium. But how are we going to do it? It's very hard. Where do we get our sodium? We get it in bread, meat, canned products. It's very hard to modify that. But we know the pyramid of diet, that the things that we should have less of, fat, salt, sugar, and things we should have more of, that some of these things are a bit more expensive, a little bit harder to get. In Mongolia, I go into the supermarket, there's rows and rows and rows of canned food, which have got huge amounts of salt consumption. They eat a lot of meat, but it's a landlocked country. It's very hard to get fresh fruit and vegetable in. And you go into the supermarket, there's just a small area there with fresh fruit, plastic, which goes rotten after 2 or 3 days, and it's very expensive. So it's a challenge. You have to work with industry, you have to work with government. Government gets money from salt. So it's challenging, but we have to do it. So how else can we control blood pressure in the community? Well, here's a very nice trial published in The Lancet using community workers. You don't need doctors. There's not enough doctors to go around. Let's see if we can get health benefits from community workers. So they went through villages in China, got lay workers to work in the community, detect blood pressure and titrate their blood pressure control with extra pills. And in the blue group here, which is the intervention group, they could get blood pressure under control quite well, as opposed to usual care, but it did take 3 years to do it. And this brought about significant improvements in overall cardiovascular disease and specific endpoints. So you can do it, screening healthcare workers in the community and encouraging people to go on treatments. What we've been focusing on is cheaper, easier way for people to take their pills. Now, in medical school, we've conventionally been told, start a pill, go carefully with the patient, go it up to the maximum dose, make sure everything works before you move to another pill. And in hypertension, that can take 6 months to get blood pressure under control. We think that if you can put 2 or 3 or 4 pills together at a very low dose, just start them on, you'll get a big blood pressure effect, good tolerability, and you'll get the blood pressure under control very quickly. And we've shown this in a few studies here. One in Nigeria, population-based study, implementation, no control. An open trial here of a low-dose combination versus usual care. You get a bigger effect with the polypill. And then we did a quarter dose, much quicker reduction in blood pressure and difference of the combination. And we're testing this out, and you get, this is a follow-up to our Sri Lankan study, you've got better overall blood pressure control between the 2 groups. And this is what WHO is recommending here in their guidelines, is to use single combination pills where possible. The only problem is they're more expensive at the moment. We need things that are lower dose, lower cost, and this is what our group at the George have done, is we've created a triple pill with an ARB, telmisartan low dose, a calcium channel blocker, amlodipine low dose, and a diuretic. We've put that together in a single pill, bespoke, so all the chemicals are mixed in together. It's a little like a wafer. And we're doing this test in intracerebral hemorrhage because, again, blood pressure control is very important in ICH patients. this could be a very simple way that we could roll out this type of treatment in various low resource settings. And we're about 1,200 on the way to 1,500. Taken us a while getting through COVID and recruitment, but hopefully we can get a result from this big trial in 2014. Did want to bring the trial to Chile, but there were some problems with the regulatory system here that made it difficult. Oh, yeah, so this is we've been going a while. To do clinical trials, you have to be patient and rigorous to keep things going. I think there was 2016 that we started that. So let me just finish with a little bit more clinical effects. This is what I've been talking about for people here who haven't seen a blood in the brain. This is the hematoma of intracerebral hemorrhage, and this is a CT scan. And it's very easy to spot. It glows like a light bulb, and it expands very quickly. There's what we call this hematoma growth. And so theoretically, if we can get a treatment early, we might be able to reduce the bleeding. It's a bit like plumbing. If you can reduce the pressure in the water pipes, theoretically you can reduce the bleeding. And this is what causes the problem and the death of the patient. If this expands and it's in a box, the skull, basically there's no room for the brain to go, and so the patient can die in a big bleed or damage and split the brain and cause a disability. And so we know now we can look at the pattern of the bleeding, look at the location. It can help determine our treatment strategy, but also we've got to take into account the patient. So the prognosis for recovery is dependent on the age of the patient. There's signs of frailty in the brain. They often come along with kidney problems or heart problems that's going to affect their recovery. But we've been doing a lot of work to see whether, if the blood pressure is elevated, can we bring this hematoma under control quickly. And this is what we call a meta-analysis, where we put all of the trials together of early blood pressure lowering. These are the two trials I led here, the early INTERACT studies, with sort of a suggestion to the left of benefit. A lot of the other trials didn't show much, showed a reverse. So overall, looking at all of the evidence on any type of treatment, pretty neutral on unity. But with a meta-analysis of this size, we can look at particular subgroups. And in the subgroups, we did see some differences, what we call statistical heterogeneity. So where you can titrate the blood pressure down, clear benefit, as opposed to just a single agent. We did show there was a difference in the type of drug you use, which is quite interesting. In this data, we didn't show any time relationship, so early treatment under 2 hours versus later. We couldn't show a lot of difference here. But we did show very reassuringly that you can reduce blood pressure. You can reduce hematoma growth in the brain. And that was highly significant, but it's pretty small. It's only about 1 ml overall. So it's a modest treatment effect. There is some evidence from post-hoc analysis. This is a big trial called ATAC2 and ATACH2, where they did look at subgroup people who were treated very early. There was significant signs here that you could reduce hematoma growth and disability. But this is what we call post-hoc analysis, hypothesis generating. It's not very robust. There have been some other trials. This is a big ambulance trial. So if you want to get blood pressure under control early, why don't go into the community when the patient's being retrieved in the ambulance? And in this trial, they used a nitrate patch. So it produces, dissolves the drug under the skin. And Surprise, surprise, no overall effect on everybody who had a stroke, but there was a harm for people who had intracerebral hemorrhage. More deaths, more disability, and more bleeding. And so it worried people that maybe the nitrates, which might open up the blood vessel and maybe cause more bleeding, is harmful. And in fact, there was another trial which was done in Holland called Mr. ASAP, and they followed the same sort of protocol to use this nitrate disc. And you can see here in this modified Rankin scale again, this is good scores here, bad scores here. The distribution is not looking good for the GTN group. And in the people who had intracerebral hemorrhage, there was more bigger volume, bigger hematoma growth, and more deaths. So the ethics committee decided to stop the trial. They were worried that it was causing more harms. So potential sign of early harm for GTM, so it's not recommended. So at the moment, blood pressure control in the ambulance is a little bit uncertain, but I've been working with colleagues in China for the last few years, Interact 4, to see whether we could use a different approach with a bolus, a different type of drug, in people who are hypertensive. The ambulance staff pick the patient up in the community, they've got a severe type of stroke, and we randomise them to rapid blood pressure control or standard blood pressure control. We're on schedule. Actually, we just passed 2,000. Our target is 2,500, and hopefully we'll get a result. And I just wanted to show you that we're working in a urban high income area in the east, particularly around Shanghai, and we're dealing with a low resource setting here. Again, we're emphasising the pattern of intracerebral hemorrhage and the type of patients and how the ambulance system's organised. I just wanted to show you the blood pressure curve. So this is, we are getting a difference. This is the intervention group versus usual care. So overall, patients are presenting here maybe around 180 overall. It's a little lower for ischemic stroke, and we're getting a little difference, a smaller difference. But then you look here for intracerebral hemorrhage, mainly they're higher, and there is evidence. We're not robots. Our blood pressures are not stable all the time. They fluctuate. And if your blood pressure does peak, it goes up, it can cause bleeding. This is evidence to suggest that higher blood pressure, but we're also getting it under control much quicker in the ambulance, which is very reassuring. So we're quite hopeful that we could get some real evidence here to suggest that blood pressure unstable in the community, causing the bleeding, if we can get it under control early, that might be beneficial. So let me summarise. Huge burden of intracerebral hemorrhage on a global scale. Its impact in terms of death and disability is pretty severe. It's a disease of low resource and deprived populations, and it's all driven by hypertension. And so clearly, if we're going to make a difference, we need to have better public health approaches. So I've talked about diet, salt, fresh fruit and vegetables. We've got to find the people who have high blood pressure and get them on treatment, make them understand how to take their pills, use some simple approaches to get blood pressure under control. Potassium-enriched low-sodium salt is a good option, and we've got to work with industry and government to get that in as policy in our cheese, in our meat, in our bread. Some other approaches, there's a triple low dose, simple low-cost approach, or polypill approaches, very good for low resource settings. To improve blood pressure targets in high risk, and intracerebral hemorrhage patients really need to, as a clinician, we really need to work well to get their blood pressure under control. I've talked about getting aggressive early blood pressure control when the patient comes to hospital. and then clearly also pretty important for secondary prevention. So I think that's my last slide, and very happy to open it up for questions and feedback.
Preguntas, si alguien necesita hacerla en español, podemos ayudar a traducir aquí.
I have a question, Craig. Thank you for great talk. So do you have any idea why South America is very underserved as it is parts of Southeast Asia and Africa? However, in the map you showed, it was quite blue or light blue. It didn't look red or as the other parts of the world. Is there any reason for that?
I think part of the reason is it's related to the risk, the rate. The rate's dependent on the structure of the population. It's a little bit younger here as opposed to older, so it's probably the risk of the disease in the population at large.
Is that metric dependent on the assessment system of each healthcare system in every country? How do you equalize the information you get from each country?
So they try to use a standardised way to adjust for the population size. So they use a sort of WHO standardised population. So they take the crude rate in the population and convert it into a uniform metric. That's the pattern that you get.
Yeah. Sort of in the same line that Jose was asking, does this have anything to do or has it been corrected by drug availability? Like, is it due to anti-hypertension medicines being available?
Yeah, look, I guess, it's just counting numbers, and so it's just the number of events in the population. And it's primary events, so this is first ever events, so that, the population is also dependent on their treatment. So in countries where you've got good treatment, the rates will be a bit lower. And there's the person risk, obviously their age and diet and hypertension, but also levels of control, so I agree. So it's a simple metric, basically, depending on what's ever happening in that population.
The populations that you are studying over the years, do you see opposite trends in different groups of one population? So one is increasing and the other one is decreasing?
So the good news in Western populations, and I think we can apply that to Santiago, that actually the risk of stroke is going down. We're a bit healthier, we've got more access to healthcare, we've got better drug treatment. So, Framingham and other countries, they show overall in the population the risk of stroke is going down, which is good news. But within the population, the patterns are changing. So what we've actually shown, and which is worrisome, is that the rate of stroke in young and middle-aged people is actually going up. And the rates of smoking in younger people, particularly younger women, is going up, and obesity is going up, and also the recognition of hypertension in young people is not really there. So overall in the population, which is, it's a sort of, our population's a sort of middle bubble, the rate of stroke is going down, but there's some changes, and obviously lower socioeconomic groups here, it's going up. So again, in rural areas, as the rural area improves its healthcare system, the rates go down. So there's some good data there. The other thing about Mongolia that I didn't mention, and it's probably relevant here in Chile, is that extremes in weather, temperature, affect your blood pressure. systolic blood pressure can move about 10 millimetres between summer and winter, and presumably also the fluctuations. If you go outside your home in very cold weather, the cold on your face produces a diving reflex and cerebral blood flow. So that's one of the theories behind why there's more heart attacks and strokes in the morning. Getting up, blood pressure's going up, you race outside in the cold, and put your blood pressure up, cause more strokes. So the thing about Mongolia, it's extremes of temperature, minus 30, poor blood pressure control, and clinicians in northern China and Mongolia, they'll say it. In winter, they have all the bleeds coming in. And then the summer it drops down, a bit more manageable. I'm sure the same pattern here in Chile.
Thank you for it was a great presentation. I just saw a research study that said that, as you said, that younger people are having more strokes, and one of the reasons they said it was for contaminants. Do you know which contaminants are related to stroke? Is it just smoking?
Look, smoking's the strongest risk factor, but drug use. That's, amphetamines, cocaine. Chronic use can damage the endothelium. Acute use can put the blood pressure up and change your clotting. It's a minority of the population, but it's a concern. I'm not aware of any other sort of nutritional things. People worry about heavy metals and pollution in the water, but I think that the evidence for that's pretty weak. Car pollution is an issue, PM 2.5, and Santiago with your valley, your air, there's a bit of a worry. There's good evidence now that air pollution is linked to stroke. And again, using Ulaanbaatar, it's in a valley, and in the winter they burn more coal, and coal contributes to air pollution. And again, I'm sure that's an issue here in Chile. Keep warm, more coal burning, wood burning, more pollution.
So just a comment. Thank you very much, Greg, for the talk. So I would like to highlight a couple of things, and would like to thank you for all your collaboration with different trials and stroke trials. So one of the things that I think is difficult to measure, but has been very important, is because we have participated in these projects, stroke projects, for example, for ICH in the country, in different areas, in different hospitals all around the country, putting these patients as important patients and teaching the groups, the treating physicians, and the whole professionals around the patients that these patients are important, and how we can change and modify the care of the patients around the clinical trial is important for having better treatments. So how participating in clinical trials can actually change the behavior of professionals around these patients, more on top of what we are doing as intervention in the trial. So I think this is something that is very important to mention. This is something that also gives us an opportunity to work with them in another project as well, so teaching them and having more professionals knowing about research. And the other thing is that the opportunity to bring projects probably related with bundles of care, more than one medication, because as we have all mentioned a lot of times, we have a difficult regulatory system and laws that probably make it very difficult to bring a drug out from outside and try it in a clinical trial, but we can do these kind of studies that are simpler, but they are not really simple. They take this bundle of cares, and maybe something related with diet would be interesting to incorporate. We can do things related with salt reduction and everything that is related with that. So I think we have a good opportunity opportunities, and thank you for all the work that you've done.
I think for the trainees and students here, I mean, there's very good evidence now that organisations, hospitals, medical clinics, and patients to participate in medical research gives benefits over and beyond what you're actually testing. You get more informed by the people who are caring for you in the clinical trial. You get access to new treatments. You're almost like gold insurance. Of course, if a problem happens, the medical doctors or the people involved in your medical research need to be informed quickly and action it. So it's almost like you get a gold card for referral to get it sorted out quickly. So doing research is very good. It's good for the organisation. You get smart people, you get more informed. It's good for your patients. But to do clinical research is tough now because there's all these regulations, the ethics. You've got to make sure that the experimentation is done well, that people are adequately informed of any risk. There's whole issues now about accessing data, privacy protection, and so at a community level, you know, we are becoming a little paranoid of breaches of our security, accessing our banking details and those sort of things. So we have to be careful. You know, we're all doing medical research. I think there is a little bit of a reluctance to participate and share their data. So I think, again, as an institution, raising awareness of the importance of clinical research and how important it is for the health of our country and our population to be investing in research is really important. And to make people aware that to do research is good. So we have to do that as well.
See, I think it was very interesting that you were successful when treating patients with a combination of drugs. And I have two questions about that because you use a combination of drugs with low doses, and it was more successful than using one drug with a high dose. So one question is, did that have fewer side effects than the high dose drugs, or new side effects emerged after the combination of the drugs? And if you think if that is successful because of something particular of the circulatory system diseases, or we should be trying to use a combination of drugs in other diseases too?
Yeah, they were all very good questions. So let me deal with the drug question first. So with any drug, most of the benefit comes in the first few doses. You know, normally there's a pattern, low, medium and high. So most of the benefit of the drug happens by medium. You might get an improvement by maybe 10 or 20% by going from middle to high. And if you push the dose, then you get more side effects. The advantage of putting a combination of drugs together at a low dose is they work in an added fashion because they're using different mechanisms in the body, different receptor blockages. You're not pushing the high dose, so you get a side effect, so you get added. So that's there's quite good evidence there. I've always, being a trialist and as a clinician, you'll hear, if you put a few things together and you show a benefit, we don't know what works. And there's this temptation, and it's human nature to try to unpack it and work out, what's working and what's not working. And sometimes we lose sight of the fact that it's working because they're working together. But we have this sort of intellectual curiosity, or somebody will tell us, get rid of the more expensive one and just keep the cheap things, or something like that, a resource rationalisation, and we lose sight. But if we use the analogy of different drugs, we can also apply in the way we organise our health system, because nothing ever works perfectly. And the best we can do in taking pills is maybe we take them 70, 80% of the time. Maybe we forget it a couple of times during the week. You know, most people don't take their pills very well, so you'll never get perfect treatment with any. But if you put a few together and accept imperfect for a few, together gives you I think it's quite good. So I'm coming round to thinking, you know, bundles of care together, if it works and it's easy and affordable, that's probably good enough, like a drug, systems of care.
¿Alguna última pregunta? Si no, yo me voy a... Bueno, agradezcamos nuevamente a Craig. Yo voy a colgar de su diapositiva de lo bueno que es el consumo de fruta, porque el Pizza and Beer de hoy va a ser el Anti-Pizza and Beer organizado por el Centro de Estudios Clínicos. Muy en la línea de lo propagandeado por Craig. Así que vamos todos a la salida del aula magna y nos encontramos ahí en unos minutos. Gracias.
Lo que dice ahí. Llegó la visita de Mario.
Sí, no estamos medio vamos al sur. Vamos a la Patagonia. Primera semana de todo el paine.
¿Todo bien?
Muchas gracias.
Yo me fui en auto por ahí, en Seminario. Claro, es súper lindo. Bueno, en estricto rigor.
En el chiste de Barcelona, en el mapa, como de Valdivia.